Yes, Nisha, you may start.
Yes, sir. I welcome you all to the online teaching course for postgraduates in pathology. Today's session is on accessory cell lesions case studies, and the presenter for today is Dr. Anita Borges. She is lab director, consultant pathologist at Center for Oncopathology, Mumbai, and chairperson is Dr. Manju Sengar. She is professor, consultant medical oncologist at TMH Mumbai. The program coordinators for this program is Dr. Sumit Gujral and Dr. Anita Borges ma'am. And moderators for this session is myself, Dr. Nisha Modi, and Dr. Uma Shankar sir. In case of any audio video failure, click on the reconnect button and type all your queries in the chat box. There are a few reminders before we start. In case of connection interruption, video freezing or video lag, press the reconnect button and please do not type anything in the chat section when you are answering the polls. Click on the options provided. These are few disclaimers. You can go through them. There are a few more. Now let us start the session. I request Borges ma'am to start her screen share.
Okay.
And you may
Share. Can you see my screen?
Yes, madam.
Yes, ma'am. Screen is visible.
Yes. Yes.
All right. So good evening, everybody. Welcome, Manju, to our online teaching program for pathologists. Thank you so much, Uma and Nisha, for being moderating there. And of course, thank you, Sumit, for always being around to help us through this. Help dinosaurs like me. And you can see one over here that I have put up on the screen. And I've entitled this talk, Curiosa et Exotica. Now, if you know what this means, it means just curious and exotic things in general. And I think if you have not seen a particular animal or a particular thing, and somebody just describes it to you, you sometimes get a very lopsided or even a very fantastical view or opinion or even a thought about how this can look. And you can see this over here, that there is somebody who was just described as to what a rhinoceros is. And some part of it, this person got right, and that is the horn over there and all these very plate-like, armor plate-like structures during the body. But somehow or the other, this particular artist felt that this rhinoceros had a kind of a dragon-like neck. And therefore, this artist drew a rhinoceros in a very fantastical, or as we will call it, a fabulous kind of way, like fables about it. Now, I think that accessory cell lesions, particularly their proliferations, can be somewhat like that to people who have not seen them. And why is it that people are unlikely to have seen them? And I mean postgraduates, those of us who have been working in histopathology for a long time, over a period of time, we do come across these lesions, but they're very, very uncommon. And that's why I thought that it might be as well to talk about accessory cell proliferations and show you some of the varied presentations that they have and the histology that may vary from one lesion to another. Now, all I want you to do is to pay attention for the first maybe 20 or 25 minutes, and thereafter you just let the histology slides and the thing just wash over you. And don't be afraid, because you are very unlikely to come across these lesions. When you do, you will probably require, if if you're not in a busy lab, you will probably require to get a second opinion. But still, I think it's worth knowing what these are, because many of them are very treatable, and some of them, no matter how hard you try, they are not very easy to treat. So if I can have the first poll question now, Nisha or Uma.
Yes, ma'am.
Yeah, it's just what is an accessory cell, and I would like there are 6 options here, but choose the right option, because you one or the other of the options, or even more than one option, may actually describe or pertain to what is an accessory cell. But I think there is one option over here that is most appropriate. So I don't think it will take very long, but you let me know, Nisha, what.
Yes, ma'am. Yes, ma'am.
Are they still answering? My gosh.
There are 53% people, they have answered all the above.
Uh-huh.
And yeah, and 31% says a histiocyte, 7% says an antigen presenting cell,
Okay.
whereas 1% says a phagocyte.
All right. So anybody, the majority, I think you said 50% said all of the
59% said
above.
all of the
How
above.
many said 50%, 59% all of
59.
them? Yeah. Well, that's not the most appropriate answer, because a lymphocyte is not an accessory cell, an NK cell is not an accessory cell. So straight away, all of the above is not the right answer. The right answer, that is, fits all parts of what an accessory cell. It's either a histiocyte or a dendritic cell. What we mean about dendritic cells and histiocytes, you will come to understand as we go along. It's not only a phagocyte, it is not only an antigen presenting cell. So histiocytes and dendritic cells is the most appropriate answer. So specifically, if you want to know what is an accessory, you know what is an accessory? If you must have heard, no, if somebody murders a person and somebody, or even somebody commits suicide, and then there are people who are arrested because they were an accessory to the murder or accessory to the suicide. What does it mean? It is somebody or that assists, in the main function of, which was, I gave you an example of murder and suicide, which is not a function, but it is a cell that will assist in the adaptive immune response. Now, some of these cells may also play a role in the innate immune response, but by and large, they help or assist in the main immune response. Okay. Now, let us look at what we will consider to be accessory cells. All right. So, accessory cells, and this is, you can look up the modified, this I have modified from WHO 2017. And we will see later whether this actually applies to all the accessory cells that if you go and look up accessory cell in WHO 2017, you won't find it. They are all, all these particular cells and their lesions are all under the histiocytoses. Okay, so that's the general chapter under which you will find it in WHO 2017. But there are various definitions in people's minds about what is a histiocyte and what is a dendritic cell. And therefore, I thought it would be far better to group all these cells, which in any way have a function that assists in the immune response, accessory cells. Now, there are 2 kinds of accessory cells. And when I say 2 kinds, there are 2 groups. You have those that arise or are related to the myeloid stem cell, and others that have a relationship to mesenchymal stem cells. So they have no relationship to the hematolymphoid system as we understand it. Okay, so that's the mesenchymal cell part. Now you have precursors, and you have those of these cells that reside in the tissues. Now, let us take, we don't know anything much about the mesenchymal stem cell precursors. Okay, so that's why you see that box is empty. But in the tissues, yes, we do see the most common one being the follicular dendritic cell, which is present in the lymph node and in the germinal center. And it's very strange, isn't it, that this is a hematolymphoid organ, and in this hematolymphoid organ is a dendritic cell, and you can see that all the dendritic cells, and this one in the germinal center has got enormous numbers of these processes, and that's why it's drawn here as a very starry, if you might say, or a cell with lots of processes, and it is found in the germinal center, and we'll talk more about that later. And it arises not from where you would expect hematolymphoid or a cell that is so involved in hematolymphoid, the immune function should come actually from a mesenchymal stem cell. The other one, we don't notice it very often unless we look for it very particularly, and that too by doing immunohistochemistry, is what we call a fibroblastic reticulum cell. Now, I've shown you over here, and we'll reiterate this again and again, what are the markers by which you will be able to see it. Let's just take the mesenchymal stem cell at the moment, and you'll see that the follicular dendritic cell, the common markers that we use are CD21, CD23, CD35, and podoplanin, as I'm sure some of you know who use a lot of immunohistochemistry, is commonly known as D240. And you see something strange here, that the fibroblastic reticulum cell is can express keratins as well as muscle-specific actin. Could be smooth muscle actin or any other actin. All right. Now, on the myeloid stem cell type, then you see that there are quite a number of different cells, and we know about the monocyte precursors. There are precursors of the Langerhans type dendritic cell, and there are precursors of what we call the plasmacytoid dendritic cell. And if you look very carefully, you will note that there are three markers. If you have CD1A, CD11C, CD14, that vary between these three precursors. You don't have to remember it. It's something that those who do a lot of flow cytometry, or sometimes those who have the requisite immunohistochemistry, certainly CD1A is something that we use on immunohistochemistry. But I just wanted you to know that these precursors have differentiated from that primitive myeloid stem cell into three different types. One has got expresses CD11C and CD14, and we all know that CD14 is a very good marker for the monocyte macrophage type of cell. Then you have another group of cells, and of course it doesn't have CD1A. Then there is another precursor which expresses CD1A, does not express CD14, but does express CD11C. Right now, that is the precursor that gives rise to the Langerhans group of cells. Then you have dendritic cells, and then you have one which has neither 1A, 14, or 11C, but does express on many occasions CD123. Now, when you go to the macrophage lineage, in addition to this, this profile that I talked about, lack of CD1A, but positivity for expression of 11C and 14, the precursors express CD68. Now let's look at how they differentiate. The macrophage ones, I think we know, whether they are monocytes that are present in the peripheral blood or some macrophages that are in the tissues, they will express CD68 as well as CD163. Of course, they will have their lineage-specific markers at CD14 and CD11C, but they do not express CD1A. There is this, and I haven't boxed it because I also don't know how to recognize the interstitial dendritic cell. It is a cell which is, for all practical purposes, there. It's theoretical. We don't really see many proliferations of this particular cell. On the other hand, when you come to this group of precursors which expresses CD1A, you'll find that you have the Langerhans dendritic cell, which is CD1A positive, S100 protein positive, and expresses something called Langerin in honor of Langerhans, who described the Langerhans cell. It's the name that is given, like all the CD marker names, it's CD207. Now that, there is a kind of interlinking of the cells that are in this Langerhans group. There is one which is called the veiled cell. Yes, it is CD1A positive. It is S100 protein positive. It expresses Langerin most of the time, that's CD207, but it can be variable. On the other hand, there is another group of cells which does not express CD1A, does not express Langerin, but only expresses S100 protein. Okay, and that is what we call an interdigitating dendritic cell. Now, where are these placed? If you look in the lymph nodes or you look in some other lymphoid organs, you will find that they occupy the T zone. All right, so you expect to find interdigitating cells in the T zone, largely in the T zone. You do find some Langerhans cells and you do find veil cells, but where you find the most of these Langerhans cells and veil cells would be in the skin and sometimes in the bone marrow. So if you want to look for a Langerhans cell, then look in the skin. Veil cells in the skin. You want to look for interdigitating dendritic cells, then look for it in the T zone of the lymph node. And then you have the plasmacytoid dendritic cell, and you've probably heard about it in the context of Kikuchi's disease, where the so-called histiocytes that you see in Kikuchi's disease is really express this immunophenotype of a plasmacytoid dendritic cell. And it has, the activated plasmacytoid dendritic cell has a lot of role to play, particularly in viral and some immune responses. Okay, so now just to flesh this out a bit, we've talked about the dendritic cells and the histiocytes. Now let's see what their proliferations and tumors, what do you expect from these? And I think it's not difficult to even imagine that. Let's take it at the level of the precursors. You know that this is, AML that arises from the monocyte. So it's a monoblastic type of AML or combinations of myelomonocytic AMLs. And here, of course, you would have to look for the precursor protein or precursor expression, and that is CD34. If you take this tumor, which is known as present again as a precursor, it is the BPCDN, and we'll talk a little bit more about it, and that is blastoid plasma cell dendritic neoplasm. That is what you see as a proliferation, as a tumor, and it is a very aggressive precursor cell tumor. You don't see too many proliferations or tumors from the plasmacytoid dendritic cell. I told you that you encounter it in diseases like Kikuchi's disease, where you may get sheets of plasmacytoid dendritic cells, but they are all reactive. But you do get proliferations of the Langerhans cells, and we'll come to that, and you do get proliferations of the interdigitating dendritic cells, which are known as IDC tumors, and Langerhans cell histiocytosis. We also have the ones that belong in the macrophage monocyte system, and this is Erdheim-Chester disease. You have Rosai-Dorfman disease. When you look at it in the skin, it is juvenile xanthogranuloma, and the malignant counterpart of this monocyte macrophage system is referred to as malignant histiocytosis, or nowadays the preferred term is histiocytic sarcoma. And you come to the other side of the mesenchymal stem cell, and you'll see that you get follicular dendritic cell tumors, a lot of the time they behave as sarcomas. And you have the fibroblastic reticulum cell tumor, which, yes, you do see occasionally, certainly not as commonly as the FTC tumor. Okay, now we come to the part where you have to pay a little bit of attention. Okay, that was the WHO and the way that we normally look at histiocytic and dendritic cell proliferations or neoplasms. But there is a society which is called the Histiocyte Society. Okay, and it's been active for many, many years. And there are people who work entirely on this macrophage dendritic cell lineages. And I point to the fact that these are all the lineages that arise from the myeloid cell, the myeloid stem cell. So there is nothing about the mesenchymal stem cell that this histiocytic society does. And please take this reference down, because this is the most recent publication from the Histiocyte Society. Every 3 or 4 years, they, just like the WHO, they update their classification of what they call the histiocytoses. Okay, and this time they have come up with 5 groups. And these groups are L, C, R, M, and H. We will go through them a little bit in detail, but I've just shown you the diagram here. You see all the cells, and you see this L, C, R, M, and H. And when you see, it makes sense that the Rosai-Dorfman disease group is called R. You see the cutaneous group, which is largely of this juvenile xanthogranulomatous type, is called C. Okay, that makes sense. Okay, the malignant ones are known as M, and you have HLH, that is the hemophagocytic lymphohistiocytosis. Okay, that's called H. And you would expect that the Langerhans cell would be L, but you suddenly discover that something that comes from the macrophage lineage, that is, which we call Erdheim-Chester disease, which doesn't look dendritic, it does not express CD1A, it almost never expresses S100 protein, and never expresses Langerin. And you wonder, why is it that both of them have been put into the L group? And you can see it here. LCH, this is that indeterminate cell histiocytosis, and you have Erdheim-Chester disease. But underneath that, notice that there is something called mixed LCH and Erdheim-Chester disease, and that gives you a clue. So let us look at this L group histiocytosis. And I told you that they have combined 2 of these groups together. One is got dendritic cells, look at its immunoprofile. Langerin, CD1A, and S100 protein is the least specific of these all. And the macrophage type cells, which CD68, CD163 positive, and never express CD1A. So why have they done that? And the answer is here. Both of these groups of cells have mutations in the V600E in BRAF, or their MAP kinase pathway dearrangements are seen. And it's peculiar. There doesn't seem to be anything in common except at the myeloid stem cell level that should, have 20% of patients with Erdheim-Chester disease also have Langerhans cell histiocytosis. Okay, and both conditions are associated with similar clinical complications, such as diabetes insipidus, which means that they affect the pituitary, and or some neurodegenerative disease. So the members of the Histiocyte Society say that there has to be an explanation as to why These two types of cells actually share some things in common, and this may be because this BRAF V600E mutation or some MAP kinase pathway derangements have taken place at some stem cell level, and these cells, as they differentiate either into the monocyte macrophage pathway or into the Langerhans cell histiocytosis pathway, they still retain these, the memory that they may of their origin from the myeloid stem cells, and they may occur in the same patients, which, Erdheim-Chester disease can have Langerhans cell histiocytic lesions and vice versa. Okay, so that's basically what I wanted to tell you about L group. C group is all these cutaneous juvenile xanthogranuloma, solitary reticular histiocytoma. We don't see very many of these. Those who are, skin pathologists who do a lot of dermatology would obviously see a lot of them. They can either be localized to the skin or they can be, disseminated, as you see at the bottom, but they express CD68, CD163, and sometimes S100 protein. The M group histiocytoses are all malignant. Okay, that's why they call it malignant histiocytosis. They can be primary, and then it can be in the skin, lymph node, could be in the digestive system, wherever, the central nervous system, either localized or disseminated. But then there is something interesting. You have secondary malignant histiocytosis, secondary to a follicular lymphoma, lymphocytic leukemia, usually after treatment, but not necessarily so. Hairy cell leukemia, acute lymphoblastic leukemia, also to other histiocytoses, like Langerhans cell histiocytosis or Rosai-Dorfman disease, and to other hematological neoplasia. And there's also something very interesting. Those of you who work in oncology will have come across very uncommonly, but nonetheless, if you have a large number of cases, you will find that some mediastinal germ cell tumors, particularly teratomas, or mixed teratomas or malignant teratomas, may present either synchronously or later with a malignant histiocytosis, or what we call a histiocytic sarcoma. And so these are all malignant, and you may have a histiocytic sarcoma, you may have an interdigitating cell sarcoma, you may have a Langerhans cell sarcoma, you can have an indeterminate cell sarcoma, or they're just, that they are histiocytic, but they are not, there is no specific entity that you can tell. The R group histiocytosis, this is Rosai-Dorfman disease. What you should know about it is, of course, you diagnose it by emperipoiesis in the cells. They are all positive for S100 protein, very strongly so. They do not express CD1A. So you know that they are not Langerhans cells, because Langerhans cells do express S100 protein. They are not interdigitating cells, dendritic cells, because they also express S100 protein. But these express S100 protein but are negative for CD1A and Langerin. Okay, so they belong to a particular group of phagocytic histiocytes. They are not dendritic cells. But the interesting thing today is that you have to find out whether these tumors or these histiocytoses, they may be localized, they may be in multiple organs, whether they are associated with IgG4 or not. And and this is not such an uncommon histiocytosis, so people have seen them. They have seen them either in their own practices, or they're always seen in slide seminars, etc. There are a lot of plasma cells in these lesions. And these plasma cells are usually polytypic. Once in a way, they may be lambda light chain restricted, but today we are recognizing that they may have, they may be IgG4 associated. I don't want to spend too much time on the theory of this, but there is something that caught my eye, and that is, there is a familial form of Rosai-Dorfman disease, and one familial form is called Faisalabad syndrome. Okay, or it's also known as the H syndrome. And I don't want anybody to even, remember this, but I was curious. I said, what is the H syndrome? And this is it. The H syndrome is an autosomal genetic condition characterized by, of course, it has Rosai-Dorfman disease, but it is associated with hyperpigmentation, hypertrichosis, meaning a lot of hair, hepatosplenomegaly, hearing loss, heart anomalies, hypogonadism, low height, so short stature, hyperglycemia, because many of them also have diabetes mellitus, and hallux valgus, and they have flexion contractures, and this is a specific gene. I mean, if somebody is interested in, trivia and wants to play Trivial Pursuit or win prizes in a quiz context, then you can remember what you need to remember about the H syndrome. But otherwise, no. And I'm not going to get into this. This is the HLH group. They will express CD68, CD163, of course, lysozyme. Any macrophage may also express lysozyme. And you have the inherited forms. That's the primary forms, and you have the secondary forms. And among the secondary forms, there are many that are viral associated, and the most common virus is EBV. So just to give you a table now of what are the common immunohistochemistry markers that are expressed by the Langerhans cells, the interdigitating, I often refer to them as interdigitating reticulum cells, but they are dendritic cells. Then the follicular dendritic cells, the macrophage type lineages, and the follicular reticulum cells, which were at one time called cytokeratin, expressing interdigitating reticulum cells. Okay, so the terminology has changed a little bit over the years, but you know that these are the three more common markers that are expressed, and Langerhans must be expressed if you want to call it Langerhans cell granulomatosis, but most people don't have Langerhans. So if everything else fits, the clinical picture fits, and everything else fits, yes, you can make the diagnosis on CD1A and S100 protein. Okay, S100 protein is expressed alone in this interdigitating dendritic cell, and it's present mainly in the T zone and in the normal situation, but it can completely overrun the lymph node. May also be seen in an extranodal site sometimes. Okay? Then, of course, CD68 is expressed mainly, and 163 in those that have the monocyte macrophage lineage. FTC markers, which are commonly used, are 21, 23, and 35. And as you would expect, that in this fibroblastic reticulum cell lineage, you will get smooth muscle actin because it's a mesenchymal cell. And as I told you, many of them do express CK. So now that I've just given you this preliminary thing, just sit back and relax and look at these accessory cell neoplasms. You're not going to see too many of them in your own lifetime. You will see them in collections. You will see them in slide seminars. You will sometimes have to scratch your head over them, but then I suppose a second opinion comes to your rescue. So these accessory cell neoplasms are all of these, and the ones that are ticked are the ones that I am going to show you examples of. Okay, right. So now let's come to our curious and exotic lesions. And here's the first case. It's a 37-year-old man with a swelling in the left side of the neck. It was not at any lymph node site, and we received the blocks in consultation. And you can see that this lesion has got these very hyaline bands that are dividing up this proliferation into nodules. You can see them. The nodules are very cellular. At this part, perhaps you can't see it, but there is a lot of necrosis. Okay, and here is the thing at high power. You can see that it's more or less a monotonous proliferation, but when you look at it even at this, the highest power, and I'll show you another high power, you can't make out cell boundaries. What you see is a kind of a syncytium in which these nuclei are all stuck. And the nuclei are very distinctive. They have this nuclear membrane, which is like a penciled nucleus, so very defined nuclear membrane, nucleolus. Yeah, you can see that, and a very fine dust-like chromatin. Okay, so that's what it looked like. See, look at it at high power, and there's no doubt about it. It's got mitosis. It's a malignant tumor. Okay, and you have a fine little vascularization that is going through this lesion. Here you can see more mitoses, and you see this delicate nuclear membrane, but very well defined, little dot-like fine chromatin, and where you can see a nucleus, the nucleus is small, but it is there. It is conspicuous. Okay, fine. So this is the summary of the histological appearances. I won't go on. So what are the thoughts? Now, a resident brought it to me. This was many, many years ago. And what were my thoughts? Very interesting case. And you know that when a boss says interesting case, you can bet your bottom dollar that the boss does not know what it is. Okay, so it's a very interesting case, and then you try to elicit from the residents what they think it is. Okay, so what do you ask? Well, you think it's a carcinoma, melanoma, sarcoma, some kind of histiocytic neoplasm? It's just sheets of cells in a syncytium. Remotely, could it be a non-Hodgkin's lymphoma? It's odd. I've never seen a non-Hodgkin's lymphoma looking like this, with these little dot-like nuclei. It's not a really blastic morphology, although there is, a lot of mitoses in this. And then you think, all right, if it is a sarcoma, then what sort of sarcoma? Okay. If it is in the upper neck, could it be a meningioma? Because meningiomas can be like that in sheets. If it is, could it be a salivary gland tumor? It looks vaguely epithelioid. If it is in the mid or lower neck, because all that we were told is that it is the neck. Could it be a thymic carcinoma? And why thymic carcinoma? Because you saw some wandering lymphocytes in that lesion. Okay, so then what do you say? No, why don't you go and get some clinical information? That's very typical, of the bosses. They don't know anything, so they say, go get some clinical information while they get time to think. All right, so here was a tumor situated behind the ear near the insertion of the sternocleidomastoid muscle. And then when push comes to shove, and you have nothing else to think of, you say you order some immunos. Okay, and we ordered the immunos based on what I said. Could it be a meningioma? Could it be a thymoma? Could it be a carcinoma of some sort, etc.? Odd for a thymoma in the back of the neck, meningioma, back of the ear, yeah, meningioma. Could be some parotid tumor. Could it be a histiocytic lesion? And so we ordered a panel of immunos, yeah, and they were all negative. And that was when, frustration creeps in. Now, what are you going to do? But something, and I tell students this all the time, if you don't know what something is, at least you can say what it is not. Now, we did the immunos, and we know that it's not a meningioma, thymoma, salivary gland tumor, melanoma, smooth muscle tumor, neurogenic tumor, a usual kind of histiocytic tumor, because we had done the CD68 and all that, and it was not a non-Hodgkin's lymphoma. So the question was, what had we missed? And so back to the drawing board. And obviously now, since we are talking about histiocytosis, nobody paid attention, at least I didn't pay attention to these lymphocytes. But it was not just that I didn't pay attention to lymphocytes. I didn't notice them. There's something else besides that. There are lymphocytes, but there are no plasma cells. Okay. So for you young people over there, for God's sake, stop this description of there is lymphoplasmacytic infiltrate. Okay. If you don't see plasma cells, please don't say plasma cells. And if you're saying it, it means that you've observed it. But most of the time, you just see a round cell infiltrate. It's small. You think that there are lymphocytes. Oh, no, usually lymphocytes have got plasma cells in them, along with them. This is not true. You just look carefully that there are lymphocytes, but there are no plasma cells. Okay. And then the penny dropped. Okay, I'm seeing these lymphocytes now. So let me just check whether this is a follicular dendritic cell tumor. And sure enough, it was. This is CD23, this is CD35, and it was not in a lymph node. It was an extranodal follicular dendritic cell sarcoma. Okay, so what are these follicular dendritic cells? Of course, we know that these are antigen presenting cells, holding cells, whatever you want to call them. They are of non-hematopoietic origin, and you can see disrupted networks as a diagnostic feature in some lymphomas. And the most common lymphoma is, of course, angioimmunoblastic T cell lymphoma. You can get hyperplasia, and I don't like this word dysplasia, but it is used so often you might actually see it. It just means a lot of these proliferation of these follicular dendritic cells, or even neoplasia associated with Castleman disease. And these tumors occur at both nodal and extranodal sites. And here, this is how CD23 marks it in the germinal center. They are antigen presenting cells. They are there even in primary follicles. So don't believe that they are not or they are only seen in germinal centers. It is the follicular dendritic cells that actually hold the B lymphocytes in the follicle, primary or secondary, hold them together in this spherical kind of arrangement, which we call the follicle. Okay. Now here is a PTCL of AILT type. I'm not going to get into the details, but there you see the follicular. Then it is a T cell proliferation, and you can see this is a CD20, and you can see the disrupted follicular dendritic networks. And what do we mean by disruption? They are not tight in a particular area. You cannot see a nice outline. The outline is extremely irregular. Now compare this with this. I'm not showing you the H&E, but this is HIV-associated lymphadenopathy. And you can see the follicular dendritic cells in the lymph node if you stain for them. And you see they are tight. They're tight clusters. They may not be round. They may not be spherical. They may look as if they're branching, because that is how some of the follicles in HIV-associated lymphadenopathy is. Small, large, atretic, may even be entirely composed of follicular dendritic cells. And you see the CD23 marking it. But where is this human, the HIV virus? It is sitting actually in the follicular dendritic cells. So if you do a P24 immunohistochemistry, you will find it wherever there are follicular dendritic cells. They're not in the lymphocytes. They're not in any other things. They are actually within the follicular dendritic cells. So we've learned something more now about follicular dendritic cells. I don't want to belabor this. I've already told you that this is CD23, 21, 35 are the usual markers that we do. If you have CXCL13 or you have D240, CLCX13 is the most specific and the most sensitive marker for follicular dendritic cells, but I don't think most of us have it. If you have D240, which is protoplanin, yes, you can use it, but don't forget that follicular dendritic cells are EMA positive. And if you think that something might be a carcinoma, and you do an EMA, and you don't check that CK is negative, you may actually make a diagnosis of carcinoma, it's not a follicular, it is actually a follicular dendritic cell. Now it is usually negative for all of these other markers. This is a little paper that, Dr. Jay and I contributed to, and that is identification of novel follicular dendritic cell markers. And one of them is this thing called serglycin. You don't have to worry about it. I don't think anybody uses it. It was a research paper. And this FDC secreted protein, which is FDCSP. But I'm just showing you this because this was a table in that paper, which tells you about the specificity and sensitivity of these markers. And as I told you, CXCL13 is the ideal marker. 21 and 35 are good. Because almost everybody has CD23, that's a good marker. And protoplanin is also a marker for this. So now, quickly, this is a follicular dendritic cell tumor, which looks like none of the things follicular dendritic cells that we expect. In fact, this came in with a diagnosis of ALCL. Okay, and I don't blame them, because this looks as if it's sitting in the sinuses. You see these polyploid type nuclei, a lot of cytoplasm. It could even have been a metastatic tumor or a histiocytic sarcoma. But look at it. It's a follicular dendritic cell sarcoma. So note that follicular dendritic cells, because they are of mesenchymal origin, can take on a multiplicity of appearances. Now look at this. This looks like, you know, hair, literally. It looks like, brown hair when you stain this tumor for 35 or 21. D to 40 is not as dramatic in this particular case. You see those lymphocytes, and this is in a lymph node, and it was a 60-year-old patient. Just see how beautiful this, it's whirled and swirled, and you get the ubiquitous lymphocytes unaccompanied by plasma cells. So please take that message. Don't use this term lymphoplasmacytic, as if as I say, if we didn't have the term gray-white, I don't know how students would ever or either describe a tumor. And if we didn't have lymphoplasmacytoid, I don't know, or cytic, I don't know, infiltrate, I don't know what students would do. Okay, so extranodal follicular dendritic cell sarcomas, and I showed you an example. It can look like anything, because these are tumors that have come from a mesenchymal stem cell, and it will look like sarcomas of various types, and I've listed them all over here. And very recently, we published from our lab. Ramandeep did all the hard work and heavy lifting. This is exactly what it was a review, and we subtitled it, "What the Mind Does Not Know, the Eye Does Not See." So if you do not even think of a follicular dendritic cell sarcoma, which occurs in the soft tissues, you are never going to make that diagnosis, because you would never apply, the requisite markers. If you had something like that in a lymph node, or the lymphoma pathologists see something like that in a lymph node, yeah, they might put up a 21 or a 23, or if they're doing a whole battery of stains and the 23 comes positive, then you know that this is a follicular dendritic cell. And I'm just showing you all the different types. There are whorls that look like a meningioma. There are things like this which have the hallmark cells of an ALCL. This, of course, I showed you a little while ago. And, just nondescript cells that are in sheets. Now, the question is, are there different kinds of follicular dendritic cells? Those that occur in the extranodal compartment and those that occur in the nodal compartment? And the answer is no. Okay, there are two kinds of follicular dendritic cell tumors or proliferations, and they have nothing to do with where they are situated. Okay, we also contributed to this. We did some mRNA expression profiling, and what did we find? That it doesn't matter whether they are in the soft tissue or in the nodes. There is an admixture of two kinds of subgroups, and that is those that are closely related to normal FTCs, which were called the Castleman type, and those that were closely related to fibroblasts and myopericytomas. And it is believed, but you can get this kind, that is the fibroblastic type, within the lymph node. You may get the Castleman type in the soft tissues. So where it is occurring doesn't tell you which these types are. And it is said that the fibroblast-like group has a tendency for a shorter survival. Okay. Now I'll just, have this little case. It's a lymph node. 13-year-old boy came from Afghanistan. One of these medical tourism things. Of course, before this, the present Afghan crisis. This is now almost 16, 18 years ago. And he had an axillary lymph node swelling. The lymph node was excised, and we got the blocks in consultation. And I can't ask you guys what you think, because I can't see your chat box because I've got my full screen on. But I I think that you would say that this, look at it, okay, that it has this delicate nuclear membrane, it has got a nucleolus, it looks for all the world like a follicular dendritic cell tumor, okay? It's spindly, which many of these follicular dendritic cell tumors are. And really, you can't say anything about whether there is a lymphocytic infiltrate or not, because this happens to be a lymph node. Okay, so you can't make any interpretation of whether or not you have got an accompanying lymphoid infiltrate. Very good. So these are the salient features, and so you wonder: is this a follicular dendritic cell tumor? Could it be an interdigitating cell tumor from the tumor that arises from these cells in the T-zone? Could it be a cellular blue nevus in a lymph node or an intranodal myofibroblastoma? Or could it be a metastatic tumor? Sarcoma, melanoma, carcinoma, it could be anything. But you have a strong feeling that it is one of these, FDC or IDC, okay? So we did all of what we had to do. And what did we find? No, it is not an FDC. No, of course, there is no CD30. This was not a positive for S100 protein. It was not a melanoma. It was not a carcinoma. And guess what? It was positive for alpha smooth muscle actin, and you can see it here, bottom left-hand picture. And desmin was present in this very peculiar dendritic way. Now, when you see this peculiar dendritic type desmin, and I'm telling you this, tells you that you are probably dealing with a myofibroblastic lesion. Okay, because if this were just some smooth muscle tumor, because there's so much smooth muscle actin in it, the desmin should just be like that in spindle. But this thing is dendritic. You can see the processes, and the desmin is bringing it out very well. Okay, so it wasn't any of these. So I know what it is not. Okay, if I don't know what something is, at least I should know what it is not. So then what is it? It's that myofibroblastic thing. Is it an intranodal myofibroblastoma? Fibroblastic reticulum cell sarcoma? Or is it some other funny metastatic sarcoma with a myogenic or perhaps a myofibroblastic phenotype? So when this happens now, how are we going to solve it? We thought that we should get a good history. Okay, very difficult to get the history because the patient did not, it was first of all in Delhi, couldn't speak Hindi, everything had to be done through an interpreter, but we got the history. And what was the history? It said that this little kid had a scar on the arm near the elbow. Now that made sense. So there might have been a metastasis. And it was excised twice before in Kabul, and there was a pea-sized nodule at the scar. And this is the pea-sized nodule at the scar. Okay, and what do you notice over here? It's fairly circumscribed because it's a nodule. And you see exactly the same appearance as there was in the lymph node, but you see something else. You see some lymphoid tissue at the periphery, okay, and some lymphoid tissue here, and you see this cracking artifact, like there is, space inside this tumor. Okay, you can see that. So now I'm sure that all of you should know what this tumor is. There are the lymphocytes, etc., but it is not an FTC, and it certainly wasn't an interdigitating dendritic cell tumor. So which tumor occurs in the soft tissues of the subcutaneous or even slight, the skin is usually involved somewhere or the other in the subcutaneous tissue or deep dermis of a child, and shows lymphoid tissue at the periphery and has a myofibroblastic appearance. I'm sure you know what it is now. It's an angiomatoid fibrous histiocytoma with nodal metastasis, which fooled all of us, and it looked like it was a follicular dendritic cell tumor. So it's not only that FTCs resemble soft tissue tumors, it can happen the other way about, that soft tissue tumors can resemble FTCs. And we had our, Jay did the PCR on this and showed that there was an EWS CREB fusion transcript in this case. But the moment we got that small nodule, pea-sized nodule, we knew what it was. It was an angiomatoid fibrous histiocytoma. Okay. Now here's another case. This is a 51-year-old male who underwent a splenectomy. And the gross examination showed an enlarged spleen. It was very large. And it was replaced almost entirely by a friable and necrotic tumor, which was 18 centimeters in size. And I'll just show this to you. It's a well-circumscribed mass, very prominent inflammation, plasma cells and eosinophils. Now, there is no doubt about the plasma cells and eosinophils. I'm not making this up, and because I tell people, look carefully, there are plasma cells, there are eosinophils, and this is the nature of the cells. Once again, delicate nuclear membrane, and you can see nucleoli. Okay, right. So what is the diagnosis? And this is in the spleen. So is it an inflammatory lesion or is it an inflammatory pseudotumor? Okay. Well, you have to do the immunos, and you notice there's really nothing. Those cells are not marking with 23 kappa lambda. The plasma cells are polytypic. There is no IgG4 disease. Okay, there's no desmin in this tumor, so there's no dendritic desmin or anything like that. There is a lot of SMA that is present in those, and it must be in those cells, because there's nothing else that is being overrunning this tumor, so it must be in those cells. And when you look very carefully, when we did cytokeratin, there is cytokeratin that is outlining very delicately these cells. Okay, it's not a very highly proliferative tumor because it's very spotty MIB1 labeling index. So the question of it being an inflammatory pseudotumor didn't seem very likely. So maybe it was an inflammatory myofibroblastic tumor. And normally we test for ALK1 and ROS1 because it's not just ALK that is expressed in a myofibroblastic tumor. ROS can also be expressed in a myofibroblastic tumor. They're like twins, that just like you can have this in the lung, you can get one or the other. So here also you can get one or the other translocation, but it was negative. And so somebody thought, all right, let's try follicular dendritic cell markers, and they're there. They're not marking everything, but certainly you have a blush of follicular dendritic cell tumors, both 23 and 35. And this is what this tumor actually is. It's an inflammatory pseudotumor-like follicular stroke fibroblastic dendritic cell tumor, also known as the EBV positive inflammatory follicular dendritic cell sarcoma. Okay, and just look at the EBERs in this case. It was just chock a block with EBERs. Okay, so what is this tumor? Well, it occurs in the spleen. It is a neoplasm of spindled FDCs with a rich lymphoplasmacytic infiltrate and consistent association with the Epstein-Barr virus. Okay, liver, spleen, very occasionally in the GI tract. Its neoplastic spindle cells are inconspicuous in this prominent lymphoplasmacytic infiltrate. It's usually indolent disease, and it arises obviously from an infected mesenchymal stem cell that then differentiates along the follicular or fibroblastic dendritic cell pathway. Okay, and once again to remind you, because we just discussed it in the beginning, and this is something that I have a diagram that I borrowed from Jay. I'm sure you have seen it when he talked about or he presented this particular case. We are not talking about the myeloid stem cell. We are only talking about the stromal cell over here. That's a mesenchymal cell which is probably infected by EBV, and that cell gives rise to the follicular dendritic cell and also to the fibroblastic reticulum cell. And that you get a combination of this when you get this EBV infected tumor, which is called a pseudo tumor like fibroblastic dendritic cell. It's a FTC tumor which has a pseudo inflammatory like appearance. Okay. Now we come to the next case, and this was fox dust. It was when I first started at SRL, God knows how many years ago. And one of the first difficult cases we got was this. This was a male physician who was aged 54, and he had severe back pain. He had been treated for a seminoma and was controlled for 20 years. He had no interim relapse. Okay? And there were multiple vertebrae which showed destruction. That's why he had a backache. And the imaging impression was metastasis or infection. Now, when this was a needle core biopsy was attempted, and somebody called it granuloma. And he did go on a short course of anti-tuberculous treatment, but his condition only worsened. Okay, so he had CT scans from top to toe, and except for this vertebral involvement, there was nothing else anywhere else. Just look at his ESR. So no wonder people thought that he had some kind of disease in the that was granulomatous. So in the end, they did a proper vertebral bone biopsy, and this is it. You can see the bone there, and once again you see this very diffuse proliferation, and you see some fibroblastic cells. Fibroblastic septi over there. And when you look at this, you see these pale cells in the background. And there are lymphocytes. Without a doubt, there are lymphocytes in this particular, in this thing. But you see the way that it is organized, you feel, these look like histiocytes, perhaps they're granulomas. And that was how I think on the needle core biopsy, it was called a granuloma. And to add to the confusion, look at the necrosis. So it looks like, perhaps there is necrosis, this is inflammatory, there are these cells, can't make them out too well, they're not roaring with mitoses, but they look histiocytic, so perhaps this is some kind of inflammatory lesion, may even be granulomatous. Okay, and I'm just pointing out these cells. They really don't look like any kind of frank histiocyte, but they have a lot of cytoplasm, and they have these nucleoli, which you can see, and this delicate chromatin with very well-defined nuclear membranes. And I've shown that to you. There is a sort of an inflammatory background which you would expect if this was granulomatous. Okay, you can see them again over here, and some of them are, sort of showing you a clear cytoplasm which seems to have become fused. And honest to goodness, I don't think we knew what it was. Okay, and we did the buck screens and we did everything, so we started out then looking for histiocytic markers. And this is one thing that I want to tell you. Once upon a time, long ago, we used to use two histiocytic markers in our lab. One was KPI and the other is PGMI. We no longer use KPI because it is not at all specific. And we use now PGMI, and you can see that there is some granular expression. Some of the cells might show it, but the majority of the cells are negative for CD68. Okay, we did some LCH markers. Okay, the S100 protein is negative. Says CD1A is positive, and the answer is no, it is not. CD1A is positive, because if you paid attention to, and we'll see it again, CD1A is expressed in the membrane. This is cytoplasmic CD1A, and it should not be interpreted as being positive. But look, see what is positive. After God knows half a dozen, no, it might have been 20 markers, we finally did CD23. But along the way, because we thought that it might be some metastatic tumor, we also did cytokeratin. And you can see that it's not spotty here and there, a number of the cells are expressing cytokeratin. Okay, so if you look at the immunoprofile, this is our case. Cytokeratin is not positive because it is cytoplasmic. We never did CD21 because in those days we didn't have CD21 and 35, but we did have CD23. This is way back when we started the lab, but it it showed cytokeratin. Okay, sorry, I should have marked cytokeratin over here, which I did not in this case. So what does this immunoprofile tell us? That this is a fibroblastic reticulum cell tumor with expression of cytokeratin and an FDC marker, which is this poor gentleman didn't survive very long because there was really nothing that works in these kind of tumors. FDC tumors also that are very disseminated, and we can ask Manju about it later. They're not very amenable to any kind of therapy. Pain can be controlled with radiation therapy if it happens to be, localized bone disease. So, can we have the second poll question, please? And it says the FTC sarcoma. Okay, what we've been looking at so far is part of the following histiocytosis group. You know that the histiocytic society that I talked about, they have 5 groups: L, M, H, C, or R, or of course none of the above. When they've finished, Nisha, you can tell me. Yes?
Yes, ma'am. There are 60% participants who have marked M. Option 2,
M.
M.
Okay.
M group M.
All right.
15% says group L, and 6% says group R.
All right. Well, I'm a little disappointed because it's none of the above. Okay. Did you remember that the histiocyte society has got nothing to do with the fibroblastic group of dendritic cells? Okay. And here you see it. Okay. This round circle that I am showing you now is where the fibroblastic and the follicular dendritic cell tumors come from, right? Where the histiocytosis grouping applies only to the myeloid-derived neoplasms. So just remember that. That's all. You don't need to do it. If you're going to use the histiocyte grouping, please forget about follicular dendritic cell. They don't even want to know about the FTCs and the fibroblastic reticulum cells. It's only the myeloid-derived neoplasms, okay? So the FTC sarcomas are derived from mesenchymal stem cells and are therefore not studied by the histiocyte society. And if you just understand this one thing, that's good enough, all right? Fine. So just to end this FTC sarcoma episode, the clinical significance is really difficult because they're not uncommon tumors. Some of them are intermediate grade, some can be high grade, but they're not very common. Low, they're mainly adults and they have these slowly growing nodal or extranodal masses. The head and neck is a very popular site or a common site for this. And I told you about its relationship to Castleman disease. We've seen an example of this EBV thing, and rarely paraneoplastic pemphigus has been associated with it. Well, you use a combination of surgery, radiation therapy, and chemotherapy. I don't know how effective all of this is in FTC sarcomas, but what you need to know about FTC sarcomas is you may be able to diagnose them in a lymph node. Okay, you have to some rare metastatic things like the metastatic angiomatoid fibrous histiocytoma. Sometimes you may mistake them, but it's the extranodal FTC sarcoma diagnosis is very important not to miss. Okay, and we talked about the syncytial arrangement. It's not accompanied by plasma cells, and you must know that the reticular variants express CK, also you may be fooled by the EMA expression. And those of you who have access to immunohistochemistry, just do an EMA on a regular reactive lymph node if your institution will allow you to do it, and you'll see how beautifully the EMA stains the normal follicular dendritic cells. Okay, so now we shift gears and we go to a 48-year-old male who presented with a cutaneous swelling on the left thigh, and we received a wide excision of this thigh lesion. It was 5 centimeters in diameter. Okay, and I don't think that there is a great difficulty in this diagnosis. You can see these very, very cleaved nuclei of these cells. Yeah, and some of them, of course, have a very horseshoe-like nucleus, but the nuclei are very cleaved. You can almost every one of them is cleaved, and there seems to be impingement on the epidermis, and you can see that this tumor is actually infiltrating the epidermis. You can't see much of a zone. There is no green zone between it and the epidermis. And at the bottom end, you'll see that this has infiltrated into the adipose tissue. Now you look at this at high power, and once again, it's a recurrent theme. You see cells that have delicate nuclear membranes, they have clefts in the nucleus, and a sort of, in this case, a syncytial arrangement of cells. And here you see some nuclear pleomorphism. There's no doubt about that, but look at the rest of the cells, a very cleaved and folded type of nucleus. This is the deep reticular dermis, so you can see the collagen that is thick in the reticular dermis. And I'm just showing you, look at that. Yeah, it's folded, cleaved. Some you may even think have got something that looks like a hallmark cell, but it isn't quite that. Do any of you go to any of these bakery shops? Do you know what a croissant is? Yeah, and that sometimes the croissants they make them in this crab-like shape. So that's what looks like a tumor, and you can here see actually a groove in these cells. But that was more like the more banal or bland part of this tumor, but there are other parts of the tumor that are frankly necrotic, and the tumor cells look bad. There are even mitoses to be seen. Okay, you see them at high power, you see the mitoses, you see these very convoluted and cleft and folded nuclei. So it's a malignant tumor. I think histiocytic dendritic cell nucleus sort of tumor should come up, but you can't rule out a myeloid lineage, histiocytic myeloid lineage or melanocytic ALCL. I don't think. It's not, it's unlikely to be of epithelial lineage. I would plump for this. And you look, there's no CK, EMA, 43, none of the myeloid markers. It's not 68 positive, and there's no HMB45 or melanine. It's very strongly S100 protein positive, and it is CD1A positive. And please note that CD1A is a membrane stain. It is not only, when it's thick, you might feel that it is in the cytoplasm, but it is a membrane stain. And this is the very high mid one, so this is a Langerhans cell sarcoma. Very rare disease, okay, and it's usually seen in adults. Skin is the usual site, and then you have multi-organ involvement. So let me just have the third poll question. Yeah.
Yes, ma'am. Published.
So do you make a diagnosis of Langerhans cell histiocytosis based on the expression of CD1A alone, S100 protein alone, expression of CD23 or 21, or the expression of Langerin and or Burbeck granules on electron microscopy? I think this is...
There are 87% who have voted for expression of Langerin and or Burbeck granules.
Fantastic. So that's true, because without Langerin, you can't make this diagnosis. You can make it if you have CD1A and S100 protein, yes, but you can't do it on either CD1A or only on S100 protein. This is the famous Burbank granules. They look like a racket. And you know that S100 protein is present in many histiocytic and dendritic and also melanocytic lesions. So I would never take S100 protein, as being diagnostic of anything unless there is something else that proves, what this S100 protein is marking. CD1A, I'm sure you all know, is regularly expressed in T lymphoblastic lymphoma. So please, you can't say that because CD1A is present, that alone, that this is Langerhans cell granulomatosis. So, now what are these Langerhans cells? We all know what it is, and you can see these grooves, and usually there are eosinophils. They don't always have to be there. The lymph nodes, bones, skin, pituitary are often involved. It may be localized or generalized, but this is important. When it is in a lymph node, please don't make a diagnosis of Langerhans cell histiocytosis because you have S100 protein and CD1A in a lymph node and you see convoluted or grooved or folded nuclei. Okay, this walnut-like nuclei. Don't do it unless you see a sinus pattern of infiltration. Why? Because the T zone, when it is reacting, will show you a lot of interdigitating dendritic cells, okay? And you will also see some veil cells, and you may also see a substantial proportion of cells that express CD1A. So, if it is not showing you a sinus pattern of growth, you may not have Langerhans. It is just in the T zone, in the interfollicular space. Please be very cautious about calling this thing Langerhans cell histiocytosis in a lymph node. You can certainly do it if it happens to be in the right clinical setting in the skin of a child who's got that seborrheic-like rash, often behind the ears, or the patient has got diabetes insipidus or something. But please, in an enlarged lymph node, it is most likely to be dermatopathic lymphadenopathy if this is not a sinus pattern of infiltration. Now here I show you that BRAF V600E mutation is seen, and we remember that it is also seen in Erdheim-Chester disease. Okay, and here's a case that we saw recently, and recently as last year, you can see the 20W. And this is a skin biopsy, and this is how it looked like. Note, there aren't many eosinophils, if you can see any at all. And yet here is Langerhans. CD1A, again notice that it is membrane, and since you can show this BRAF V600E mutation by immunohistochemistry, this is how it would look like if you stained it by the appropriate antibody. So this is Langerhans cell. This is a Langerhans cell histiocytosis in the skin. Now here is a 7-year-old male, and he presented with acute abdomen. Surgical exploration showed a mass in the jejunum, but no, it is an interesting history. He had a past history of treatment for T-cell acute lymphoblastic leukemia, and he has been in remission. And this is the jejunum. You see this diffuse proliferation. There is the jejunum. Look at this, diffuse proliferation. You go at higher power, you see some histiocyte-like cells with multivesiculation on one side, more rounded cuboidal looking cells here with epithelioid-like sheets, and you see, of course, the nuclei are grooved and folded and so forth. But on the other hand, look at this. This is more spindly. So you have two different patterns in this particular tumor. See it here again. More epithelioid, very definite looking grooved and nuclei, and you see some larger cells and a more spindly looking picture. So you see that I'm just showing you a whole lot of pictures over here. Large cells, yes, looking histiocytic, but you wouldn't bet your bottom dollar on it. Okay, so spindly, cleaved, and on this side more epithelioid. So on one side you have round cells, spindle cells, convoluted, folded nuclear shapes, multinucleate giant cells, some with embryoid morphology. And you think, what is this? A high-grade hematolymphoid tumor? This ALCL is always in the thing, or a histiocytic neoplasm? So myeloid tumor, there's no c-KIT, there's no CD34, there's no 20, there's no 3. There's no TDT, because remember, he had a T lymphoblastic lymphoma. So we had to check, is this now, after treatment become a myeloid sarcoma? There's no TDT, there's no 30, there's no MPO. But it was expressing leukocyte common antigen, more in the epithelioid areas, less in the spindly areas, but definitely there. 68 was virtually not expressed in those epithelial areas, but diffusely expressed in the spindle areas. And CD163 is about equally densely expressed in both the areas. There's no S100 protein, because for an S100 protein to be called positive, it should be expressed in the nucleus. Okay? And then look at lysozyme. Well, there is a smattering of lysozyme which seems to go with the 163 that we had, but it's more in the epithelioid areas and not so much in the spindle area. And CD4, you say CD4 is present, so maybe this is a T cell tumor. No, it isn't a T cell tumor. CD4 is one of the T cell markers, a marker that we commonly use for helper T cells, but it is expressed in histiocytes. So what this CD4 is telling you is that these are histiocytes, because CD3 and all the other T cell markers are negative, and yet CD4 is positive. And yes, it is a high-grade tumor. It's got a high MIB1 labeling index. So this is a histiocytic sarcoma. Yeah, and I told you, we mentioned it before, but it may precede or occur subsequent to malignant lymphomas, leukemias, maybe sometimes MDS or CLL with a Richter syndrome. And they're also known to occur in conjunction with mediastinal germ cell tumors, most commonly a teratoma. So now you've seen a histiocytic sarcoma. Now let's look at this. And all I'm saying is, don't worry if you say, oh, how am I going to make this diagnosis? You're not going to see too many of these, and just take messages from what I am telling you about things that may have nothing to do with the tumor. Okay, 20-year-old male medical student who presented with an inguinal lymphadenopathy of short duration. No fever, no weight loss, and the FNA suggested that it was a non-Hodgkin's lymphoma. And when the CT scan was done, he had multiple lymph nodes. The inguinal node was just the presenting one, but there was axillary, cervical, and he had hepatosplenomegaly. And this is his node. Okay? It wasn't a very large node, but you could see that it is diffuse. It's diffuse. Once again, even at this far, you can see that the nuclei are irregular. So what have we? There's a theme over here. Nuclei are irregular, they are cleaved, okay? They are folded, they are convoluted, and there is no special arrangement that you see in these tumors, okay? Now, we have finished with the follicular dendritic cell and fibroblastic tumors, and now we are looking at mainly the myeloid type of tumors that we are seeing over here that have arisen or have a relationship to the myeloid stem cell. Once again, cleaved. Look at this. Yeah, high grade. In this, you can see the mitoses over there. There's no doubt about the mitoses. Okay. So diffuse proliferation, and you think hematolymphoid tumor, possibly histiocytic, needs immunohistochemistry. That's the bottom line. It's not 20, there's no 3 or 5. And you go through the whole list, 2, 7, 8, 10, 23. It's a litany. It's not an epithelial tumor. It's not marking as it would never mark as a plasma cell tumor because it didn't look like that. But it comes as a whole battery of stains. Yeah, no CD30, no 61, so it's not myeloid. Yes, it is expressing LCA, and this the differentiated lymphocytes which are there in this tumor, that means B cells, T cells, whatever they are, show you this very dark expression. But you see, the tumor cells have got this very faint but very definite expression. There's no PAX5. Okay, CD117 is negative, CD34 is negative, so it's telling you that this is not, or is certainly not behaving or marking like a myeloid stem cell tumor. CD68 is negative in the tumor cells. There are the background histiocytes that have picked it up. And notice all histiocytes pick up 63 or 68 in a granular fashion. And I'm telling you, CD68, we don't use, we only use PGM1 now. If we had used the other, it would have just lit up this whole thing. It's not a follicular dendritic cell tumor. There's no 21, 23. It's not CD1A positive, but it expresses S100 protein strongly. So you all know now what this tumor is. You cannot assume that something that is S100 protein alone is, even if it is in a lymph node, is a follicular dendritic cell is an interdigitating dendritic cell tumor. Yeah, you have to make certain that it does not express the melanoma markers. And I'll tell you a quick story. I attended long ago, this was, oh God, when I was much younger, a meeting in Vienna, at which the great Karl Lennart was doing a slide seminar, and we were hanging on his every word. And then he showed us a tumor like this. And you know what he confessed from the podium? That he had put it into the slide seminar as an interdigitating reticulum cell tumor. We used to call it reticulum cell in those days. Now we call it dendritic cell tumor. And he had neglected to do HMB45 and melanate. And when he decided to do it, to photograph it for the slide seminar, it was strongly positive for HMB45 and melanate. So what he had believed was a interdigitating dendritic cell tumor was actually metastatic melanoma. So if it could have fooled the great Karl Lennart, please, we are nowhere near the great Karl Lennart. We just need to do our work in a systematic fashion. Okay, but this was negative. No Langerin, no lysozyme, no BRAF V600E. Oh yes, there is our friend CD4, because we know that this thing was LCA positive, and it is some form of perhaps dendritic cell or histiocytic lineage. There you have CD11C. Okay, so that's positive. This is nuclear phosphomin 1. We don't have it. It was done when we presented this case, for discussion at the EAHP, which is the European Association of Hematopathology. Jay went and presented it because it was, they were asking for cases that had something to do with the myeloid, histiocytes and dendritic cells. And we had this case and we sent it over there. And it was accepted and we presented it, and they did the nuclear phosphomin stain for us. Okay, this patient had a bone marrow that was done. You could see the cells in full of the cells in the bone marrow. You can see the S100 protein over there. The liver was involved, and you see the S100 protein in the liver. The small bowel of this student was involved, and you see the S100 protein that is chock-a-block in these dendritic cells. So the moral of this story is, you may never see a a tumor of this sort, an interdigitating dendritic cell tumor. But if you get an S100 protein positive, and it is not CD1A positive, if you get an S100 protein positive, please don't call it a Langerhans cell tumor unless everything else fits. If it's in the skin or this or that, and it's not an adult patient, and everything else fits, but otherwise S100 protein alone, please do not call anything a Langerhans cell tumor, however convoluted or otherwise you think it is. Number two, if CD1A is also negative, then you have to worry about an amelanotic spindle cell melanoma, which I told you even the great Carl Leonard missed. And if all of that is negative, then yes, you are okay to call this an interdigitating dendritic cell tumor. They're very aggressive and often almost invariably fatal. Okay, can we have the poll question 4?
Yes, ma'am.
Interdigitating dendritic cells are most numerous in the bone marrow, the skin, the medullary cords, the T-zone, or the follicles. And this is a no-brainer, so Nisha, what have they answered?
They're still answering.
Oh, my goodness. I can't see how many people are attending this. Nisha, can you tell me?
315.
Okay.
315 are there. 54% have voted for T-zone, 17% for follicles, and 16% for skin.
Yeah, those who said follicles, you get dendritic cells in follicles, but they are follicular dendritic cells, right? That's why we were going on follicular dendritic cells. If you have interdigitating dendritic cells, they are in the T-zone. Just remember that. It's the T-zone that has interdigitating dendritic cells will have a certain proportion of Langerhans cells, and that's why I said never make a diagnosis of Langerhans cell histiocytosis in a lymph node by itself, because that could just be a reaction. To make a diagnosis of Langerhans cell histiocytosis in a lymph node, you must have it within the sinuses, okay? And I'm not going to belabor this point. This is exactly what this really good, and it's a very recent article, the clinical, histopathological, and immunoarchitectural features of dermatopathic lymphadenopathy. And they make this a point so well that although you see the CD1A S100 protein and sometimes even Langerin in the T-zone, please don't mistake it for a Langerhans cell histiocytosis, because it's probably just a dermatopathic lymphadenopathy with or without melanin. When the T-zone is reactive, you will see, this kind of reaction in the T-zone. And I just put this up here to remind you that these are myeloid. You have the Langerhans cell, you have the Weyl cell, and you have the interdigitating dendritic cell. They share markers, but only the Langerhans cell and the Weyl cell will show you Langerin. Here, there is Langerin, but it's very spotty in this T-zone, and there's a lot of S100 protein and CD1A. And somebody might be tempted to call this Langerhans cell histiocytosis, but this is in the interfollicular T area. It is not in the sinuses, okay? So, now, question number 5.
Yes, ma'am.
The M group histiocytoses, now once again we're talking about the histiocyte society, consists of all except Langerhans cell sarcoma, follicular dendritic cell sarcoma, histiocytic sarcoma, indeterminate sarcoma, and none of the above. And we're talking now not about the WHO, we're talking about the histiocyte society M group.
Ma'am, 50% says follicular dendritic cell sarcoma.
Excellent.
18% says none of the above.
So the 50% are right. Okay, because the M group, once again, does not refer to the tumors that come from the mesenchymal stem cell. Okay, so you can have histiocytic, interdigitating, Langerhans cell, indeterminate, not specified, yeah, but you can't have, as I told you, the histiocyte society does not deal with the dendritic cells that have come from a mesenchymal stem cell origin. Okay, so follicular dendritic cell sarcoma is right. Now I think we're coming almost to the end, and that is there's this male who's 55 years old. He has had headache and disturbances of vision. And if you're looking at the chat box, when you have this kind of picture, I think if you know something about the histiocytic and accessory cell lesions, you'll know exactly what this is. Okay, the CT scan of the brain showed multiple lesions in the cerebral cortex, mass lesion in the orbit, and there is a PET scan showed lesions in the ilium and ipsilateral femur, and they biopsied the frontal lobe, obviously to reduce pressure in there. Otherwise, they could have biopsied the. And this is the brain, and you can see that here there is the cerebral tissue, and you see a very cellular tumor, and you can see even at this power that there are so many clear cells. Otherwise, you wouldn't see this very light staining area over there. Okay, now this is the brain, and there is an infiltration into the brain, and you can see that there is a perivascular lymphocytic infiltrate, which we would interpret as encephalitis. And then you come to the real part of this tumor that shows you those what looked very pale, because the nuclei the nuclei are small. They may be multinucleated. Yeah, there's nothing to say about these nuclei, but the cytoplasm is very pale and multivacuolated. You can see that. There are multiple vacuoles in the cytoplasm. Some of them have a condensation of the cytoplasm, but yes, you can see that. And these are cells that we commonly see in things like, when there is fat that is being broken down in places like paniculitis or fat necrosis. You see these multivacuolated cells. You may even see cells like this, two-tone giant cells. Yeah. So what do you think? Oh gosh, this is some kind of inflammatory lesion. Maybe the brain is breaking down, and that's why, because the brain has got a lot of fat. So this is a xanthogranulomatous reaction in the brain. And that must be exceedingly uncommon. Okay, so you don't get xanthogranulomatous lesions in the brain, but what you may get is mycobacterial disease in the brain. Okay, and this may be full of acid-fast bacilli. But no, there were no bugs. It's some non-granulomatous xanthomatous process, yes, but I don't think you can call this xanthogranulomatous inflammation. Yes, it's just full of histiocytes of macrophage type. And then you wonder, is it a storage disorder? Funny thing for a storage disorder to be in the brain. And it is most unlikely to be Rosai-Dorfman disease, because Rosai-Dorfman disease histiocytes have emperipoiesis, and their nuclei are nice, round, and have a nucleolus. So this cannot be Rosai-Dorfman disease. And what storage disorder can occur in the brain and show you, yes, multi-organ, yes, but storage disorder in the brain is a bit odd. Now you do a 68, there is some granular 68 positivity. And we also got a bone marrow, and you see these histiocytes there, and you think, so maybe it's a storage disorder. Look at them. Gaucher's, could be Gaucher's disease. Yeah, but Gaucher's disease doesn't produce big lesions in the brain. Look at those. And if you'd only seen the bone marrow, you could be forgiven for thinking that you were looking at a storage disorder. Look at the 68 in the marrow. Very rewarding to do it. There's lots of them. So this diagnosis is Erdheim-Chester disease. Okay, there were no bugs in the lesions on stains or on culture, and it was once upon a time lumped with this they were called non-Langerhans cell histiocytosis. But now we know that the Histiocyte Society thinks that it should be grouped with group L histiocytosis, and I told you why, because it shares this BRAF V600E mutation. Then this is a very useful immunostain if you have it, because sometimes if you have one of these xanthomatous things and you don't know what it is and it lights up with BRAF V600E, then you know that it has to be Erdheim Chester disease. Okay, and nowadays I'll leave it to Manju because this is not my area of interest. There is some good results that are being obtained by using some of these drugs. Okay, now I just want to ask, this was not a storage disorder. Why? Because the bone showed lesions, the brain was involved, there was no mention of hepatosplenomegaly, the bone marrow was involved, or all of the above? So what do they say, Nisha?
38% each for all of the above, and the option there was no mention of hepatosplenomegaly.
Okay.
It is almost each 37,
Yeah.
37%.
So, the bones were involved. That happens with Erdheim-Chester disease. Okay. The brain was involved. Therefore, it is not a storage disorder. Yeah. There was no mention of hepatosplenomegaly, and Erdheim-Chester disease doesn't usually give rise to hepatosplenomegaly. Okay, and the bone marrow was involved. That happens with Erdheim-Chester disease. So all of the above is the right thing. But I want to caution all you that bone marrow involvement is not the same as involvement of the bones. It doesn't apply in this particular case. But when we talk about, say, neuroblastoma, all right, bone marrow involvement in neuroblastoma is a different entity from bone involvement in neuroblastoma, where you get discrete lesions in the bone. And this is true of any kind of disease in oncology, where you have to distinguish bone marrow involvement from bone involvement. Okay? Right, now this is an easy one. It's a 40-year-old male with multiple bony lesions. Again, bones involved. Nothing much to say on the hemogram. And here's the disease, and it's involved the marrow very, very diffusely. This is a bone biopsy. This is not a bone marrow biopsy, and every bone, depending on where you take it from, will have marrow, either fatty marrow or hemopoietic marrow. But when you talk about a bone marrow biopsy, it means it's a random marrow that has been taken from the iliac crest or some other marrow-bearing bone. Okay, and I think everybody will know what this is. Look at the histiocytes. Yes, they are pale. They have nuclei, which are large, and they have nucleoli, which you can see, and the famous M. peripoiesis. That means there are lymphocytes, sometimes neutrophils and other cells that have been taken up and are not destroyed inside the phagocytic uh, during the phagocytic process. So that's different from what you see in other phagocytic disease. Look at these nice little halos around the lymphocytes and other, including plasma cells that have been, I can't use the word phagocytosed, but are lying inside these histiocytes. See the nucleolus and usually round nuclei. Although these are histiocytes, they do not have convoluted nuclei. And look at the plasma cells that are present in the background. Yeah, full of plasma cells in the background. S100 protein strongly positive, which does not make it either CD1, does not make it Langerhans cell granulomatosis, nor does it make it, interdigitating cell, dendritic cell sarcoma. They just express the same marker. And you can see that there is a lot of S100 protein in the cytoplasm, but the nucleus is also stained. This is the staining pattern of S100 protein in histiocytes. A lot of cytoplasmic staining, but there usually is nuclear staining as well. And this is the plasma cell. There doesn't seem to be, any kind of restriction, although if you look at the kappa and lambda, there should be a 4:1 ratio of kappa to lambda. There seems to be a 1:1 ratio, so maybe there is a slight lambda predominance, and this is Rosai-Dorfman disease in both. So can we have the last question now?
Yes, ma'am.
Yes, Erdheim-Chester disease is classified as group L in the histiocytosis classification because it is a dendritic cell disease. It has multi-organ involvement. It is of myeloid lineage. It shows a BRAF V600E mutation and may be encountered with Langerhans cell histiocytosis. All of the above or none of the above? Some of you may wonder why I'm stressing this histiocytosis thing. Some of you may not have heard about it before, but there is a growing attention that is being paid to this histiocyte society and its, its classifications that it keeps on bringing out every 3 or 4 years. And I think if we are going to know something about histiocytes and dendritic cells, then we ought to pay attention to things other than our standard, what the standard WHO or the standard textbooks show. It's just so that we broaden our vista. That's all. Yes, Nisha?
Ma'am, 55% says all of the above, and 35% says it shows a BRAF mutation and it may be encountered with LCH.
Now, the people who said that it's all of the above, it means that you think that Erdheim-Chester disease is in group L because it is a dendritic cell. It is not a dendritic cell. It's a macrophage. Okay? And I showed you that diagram where, you had macrophages on one side, you had dendritic cells on the other, and you had a cross, that an arrow that came across from Erdheim-Chester on the left side to the LCH on the right side, and it was put into the L group. Okay. Yes, it is of myeloid lineage, but that doesn't mean that it has to be in the group L, because all histiocytic tumors, according to the Histiocyte Society, arise from the myeloid group. It has multi-organ involvement, yeah, but lots of other things have multi-organ involvement. We just saw Rosai-Dorfman disease that had multi-organ involvement. Okay, so it shows this thing, and this is the last case that I'm going to show you, and this is a 74-year-old male who had multiple nodules and plaques over the upper limbs and trunk. A biopsy of a skin lesion was done. Okay. And here you see the skin, the epidermis, you see the dermis, and there is a Grenz zone. And the Grenz zone, for those who are not familiar, is a cell-free zone immediately below the epidermis. In any case in which there is a cellular lymphoid or hematolymphoid tumor that is involving the dermis. So if it impinges on the epidermis, then there is no Grenz zone. If it does not impinge on the epidermis, then you say that there is a Grenz cell-free zone. And it is diffuse. You see that there is some periadnexal as well as some perivascular infiltrate. You can see another low power view of the same, and you can see the Grenz zone very clearly over there. Nothing immediately below the epidermis. See it even better over here. Now, what do you see here? At low power, at least, you can see a pattern. It looks very diffuse, but you look closely and you can see these cells in cords. You know, they're marching along, one behind the other. That's very, very important as a diagnostic feature. Look at them, one behind the other, almost as we say in breast tumors, Indian file. Okay, they look at this infiltrate, one behind the other. But I know that this is not likely to be a breast tumor. Okay, the cells have got very pale nuclei, extremely pale nuclei. Now you go think back to your, breast tumor. That is the lobular carcinoma in situ. Yeah, lobular carcinoma in situ usually has a very darkish looking nuclei. It's not often vesicular. The cytoplasm of the lobular carcinoma in situ may actually have a targetoid appearance because there's mucin in it. But this is different. Look at it. I don't think you would mistake this for a breast or some kind of epithelial tumor. They're not sticking together, but they are marching one behind the other. Very pale vesicular cytoplasm. Yeah, you hardly see a kind of dusty nucleus. Dusty chromatin that you see. You know, as if there's dust that is sprinkled over this. And yes, there are some nucleoli that are seen. They're not very red. Okay, they're not very pink over here. And this, of course, is just melanin that is present in the adjacent epithelium. So this is how it looks. They're large. The nuclei are large. The cells on the whole, maybe medium-sized to large. So hematolymphoid tumor, probably myeloid, because this doesn't look like any lymphoid tumor that you know. So we did everything, the TDT, the CD117. Because it's the skin, you have to rule out a T-cell lymphoma because that occurs in the skin. And yes, it is LCA positive, so that there is no doubt about. It's CD4 positive, okay? And we've been harping on CD4. It's CD8 negative. Okay, so CD4, does it mean that it's a T-cell lymphoma? No, it is not. We've been harping on the fact that CD4 could represent a histiocytic lineage. It is also present in myeloid cells that are very primitive. So you can get 4, you can get 7 in primitive myeloid cells, and it has nothing to do with their T-cell lineage. In fact, it is not a T-cell lineage marker. CD3 is, CD2 is a thing, but certainly not 4 and 8. And then we did a CD56, because by then now we know that we're dealing with some kind of myeloid tumor which has some quote-unquote, histiocytic, dendritic type tumor. And then we did a CD123, which we hoped would come nice and strongly positive. It's a very weak stain if it is positive at all. Because if CD123 was positive, we'd have had no problems making this into a BPCDL. Okay? What is that? The blastic plasmacytoid dendritic cell neoplasm. In any case, it is the blastic plasmacytoid dendritic cell neoplasm. See, I'm showing you CD43. CD43 people think is a T cell marker, but it often marks blastic myeloid cells, and I do it. I like the stain because when it is positive and the CD3 is negative, so it is not a T cell, then this makes you think that perhaps you should investigate the myeloid cells. Okay, CD68. Well, there is some a little bit of expression here and there, and this tumor was immunophenotyped, and it shows you, as I said, 456. There is some 43, and those of you who can read the flow will tell you that there is hardly anything that is seen on immunohistochemistry with CD123, but there seems to be CD123 here on immunophenotyping. Okay, so this is the diagnosis. It's a blastic plasmacytoid dendritic cell neoplasm, which we call used to be called a hematodermic tumor. It is in this box. It is myeloid. It is not Langerhans. It is not the monocyte macrophage system. It is the plasmacytoid dendritic cell tumor. So that's what it is. It's a very aggressive tumor, and I don't think we need to get into it. Now, I know that I said that was my last case. Now, this is a question to you guys. This is a 23-year-old female with an axillary lymph node and no other complaints. So somebody knocked it off. Now, what is the stain that I should do? You can see these very pale, obvious histiocytes in this lymph node. And if there is anybody answering in the chat box, Nisha, please tell me what they're saying. What is the first stain that one would do? Anybody answering in the chat box?
Plasmacytoid DCN.
Plasmacytoid what?
No, AFB. They told AFB.
Yeah, one has said AFB, CK.
AFB, CK. Well, the person who said AFB is absolutely right. If somebody pays attention to this bottom left-hand corner, do you see what's in the...
ZN stain.
Yeah, AFB is the ZN stain. Yeah. What do you see that is filling up these vacuoles in the cells? Do you see this kind of bluish clumps that are present? You can see them everywhere. Those are globi. Yeah, so it's AFB, yes, but what AFB? It's a fight for ARCO, okay? And this is Hansen's disease of the lymph node. So you can get, just like, you can mistake an S100 protein expressing interdigitating cell tumor. You can call it that when actually it's a melanoma. Please, people can call this, the people in the chat box, some of them said that we should do CK, and some of them said that this is a plasmacytoid dendritic cell. No, it is not. This is the most common thing that we see. In this case, we didn't get any acid fast on the Zeal Nielsen, but look at the fight for ARCO, and it's beautiful. And this patient had a split skin test done, and it was full of leprobacilli. Okay, so I'll just end with this summary. It has evolved, okay? These classifications have evolved over the decades. Dendritic cells are either of myeloid or mesenchymal stem cell lineage, okay? Macrophages are always of myeloid lineage. The dendritic cells can be either of myeloid or mesenchymal lineage. And what do we mean by dendritic cells? They have dendritic processes, and the majority of them are antigen-presenting cells, either to the B system or the T system. And the B system is the follicular dendritic cells, and I hope you remember that those follicular dendritic cells, although they are present in lymph nodes under normal circumstances, they arise from mesenchymal stem cell. Now, this is important what I've highlighted. Whatever the lineage, okay, there are some common features. Delicate nuclear membranes, grooved and folded nuclei, and delicate chromatin and fine nuclei. That is as far as dendritic cells are concerned. Okay. Also remember that CD4 marks histiocytes, And EMA marks follicular dendritic cells. Do not be fooled by the common interpretation of what CD4 means and what EMA means. And sometimes cytokeratin also marks what is, a dendritic cell of interdigitating fibroblastic reticulum cell type. Okay, and I think you should think histiocytic dendritic tumor even at extranodal sites. And it is now become a practice in our lab that if you have something that looks spindly, looks sarcomatous, or even in sheets, and it is not marking for anything, then please do a 21, 22, 23, 35. You would have done S under protein and everything before, and that would have been negative. So do this and also look for MDM2 because sometimes these tumors are nothing but dedifferentiated liposarcomas. Okay, so these undifferentiated sarcomas that you cannot type can turn out to be MDM2 positive and they are dedifferentiated liposarcomas, or they may be follicular dendritic cell sarcomas. And I would just say that the last word, certainly not my word, last word has not been said on these rare disorders. So for the die-hard people who have been listening, thank you very much for a patient hearing. You didn't have much choice about sitting there and hearing it, and I turn this over to Manju. Thank you so much. But before I go, please, these four, this bibliography is important. Okay, I know that I have quoted myself in number 4, but look at this because you don't find very many large series of extranodal follicular dendritic cell sarcoma, right? Look up this paper on dermatopathic lymphadenopathy. It is a wonderful paper. All right. Be familiar with WHO 2017, and there will be another one coming out now. And if you are interested in this, in knowing what's happening in the histiocytoses, which are from of myeloid cell lineage, then please look up this paper that is there in Blood. Any paper that is published in Blood is a landmark paper because Blood does not accept papers that do not have a high impact. So if you want to you have a high impact paper, please try to get it into Blood. People would really appreciate it, and you will make a name for yourself. Okay, so this is the bibliography that you should do. And so now I will get out, and I would like Manju to say something. Get out of this. Yeah.
Thank you, ma'am. That was really a very nice, presentation and clearly describing the different types, what we see in the under the microscope. I'll just give a little bit of clinical perspective to what you have spoken. So just not to, reiterate the same fact that these are very rare tumors. So, in a year, though we, look after only hematological malignancies as a unit, and, these tumors, when they come to us, the overall put together all these accessory cell lesions, which Madam described, are not even, 15 cases in the entire year. So that's how rare they are. And a very important point is that clinically, it's almost impossible to distinguish this from the other hematolymphoid malignancies, for the simple reason that they do present with lymphadenopathy or the extranodal involvement or the extensive organ involvement. So what is important is the pathology. That's the key factor. Except if you're talking in terms of LCH and you have skin lesions, which will give you a clue that you are probably looking for a case of LCH, and that's what you're going to get in the pathology. Same way, if you're talking of blastic plasmacytoid dendritic cell neoplasm, even there you can have peculiar skin lesions which can point out towards a possibility of BPDCN, especially if the lab calls up us and tell us that there is a possibility, acute leukemia is what they are looking at. So that is something which is there in terms of the clinical presentation. So most of the times it's a pathologist who helps us in making the accurate diagnosis. A little description with regards to how you treat. So as I said, it's very crucial to know the exact histopathological subtype, because it's not that the same treatment works across. And in fact, many of the anti-lymphoma therapy also, or anti-leukemia therapy, does not work in many of these tumors. And therefore, it's very important to have the correct diagnosis. I'll begin with the, something which is rarest, or, really rare, is BPDCN. As Madam said that it expresses CD123, we have now monoclonal antibody drug conjugate for anti-CD23, which can be used in treatment. Unfortunately, it's not yet available in India. So we predominantly treat these patients with acute lymphoblastic leukemia-like therapy, because many of them have a tendency to go into central nervous system. So we incorporate CNS prophylaxis, and we give exactly how we treat an acute lymphoblastic leukemia. We'll move on to the other, one which we see more commonly. So that is LCH. And LCH in pediatric age group is much common as compared to what we see in adults. But the treatment predominantly remains on the same principles, whether you have single site involvement, whether you have multi-site involvement, and within these multiple sites, you have what we call as high-risk sites, which include liver, spleen, or marrow involvement, or CNS involvement. And your treatment depends on that. If it is single site, you can consider, removing them surgically, or you can think in terms of, giving radiation to that single bone lesion which is there. For rest, we use treatment just like how the pediatrics LCH is treated. We treat them with vinblastine and prednisolone, and we give a longer treatment for almost a year to reduce the risk of recurrence. One point which the clinician should keep in mind, that many of these patients may have endocrine abnormalities, especially the diabetes insipidus, so that needs to be taken care of while we are treating these patients. For other patients, especially if talking in terms of high risk LCH, either because of liver, spleen, or marrow involvement, then in that case we use cytarabine, and patients who fail these treatment, we do use cladribine. So that's about the LCH. The workup should include what all is involved, and that includes imaging, the endocrine workup, urine, looking at whether there is any possible urine osmolality and serum osmolality, looking at whether there is any possibility of BI. If we move to the other diseases, especially as Madam was talking about Ertine-Chester disease, there is a little bit of, improvement thanks to the understanding of biology. There is, there are BRAF mutation, there is MAP-MEK kinase pathway activation, and therefore the drugs which inhibit BRAF and MEK can be used. Unfortunately, access to these drugs remain limited, and therefore we tend to fall back onto the conventional chemotherapy. And again, cladribine comes to our help, as well as interferon. So that's something which is used, but the responses are not really remarkable, especially when you have multi-organ involvement, especially the case like what Madam showed, the CNS lesions, and you have extensive other extra CNS sites which were involved. In such situations, the responses are not good. Then you have little easier diseases which respond to milder treatment, like Rosai-Dorfman disease, and in there we use either steroids, or we use even the local excision. If it is a single site disease, then even local excision is good. For patients who fail steroids, or patients who come back after surgical excision, then one can consider using immunosuppressive therapy like 6-mercaptopurine or methotrexate. So the idea is that you don't go very aggressive, because these are relatively indolent diseases which you can treat with the milder treatment. Again, the bottom line is that you need to assess the extent of disease before you begin therapy. Something which may appear innocuous, only local, may have much more widespread extent when you do an imaging. The difficult part, which we really don't like to see when it comes, because you're suspecting that it is a nice, single node, and you get a biopsy report and it says follicular dendritic cell sarcoma, and you really hate it, because what you were expecting was a Hodgkin's lymphoma or a non-Hodgkin's lymphoma. That's what you don't like, because if it is a single site, it's good for patient, because surgical excision does work. But if it is beyond one site which cannot be excised, then it's a frustrating disease for us as a clinician. And the case which Madam showed of extensive marrow involvement, that practically calls for palliation, because none of the chemotherapy agents are really helpful once you have a disseminated systemic disease. So that's pretty much from my side. Happy if there are any questions pertaining to the clinical features or any treatment, I'll be happy to take it.
Thank you,
Thank
Manju.
you.
That was very good.
Thank you, ma'am. Uma sir will take a few chat questions.
Yeah, there are a few chat questions, but I'll take this chat question from Rai Graham. He asked how to differentiate between hemophagocytic histiocytosis and histiocyte with emperipoiesis.
Hemophagocytic histiocytosis
And histiocyte with emperipoiesis.
Yeah, well, when you have emperipoiesis, there is no phagocytic destruction of the cells in the tumor. Okay, and you see very healthy whole lymphocytes, plasma cells, whatever the cell is sitting in that particular. The moment you have phagocytosis, then there is destruction in the phagolysosome, which doesn't happen in emperipoiesis. Okay, so it's almost as if they're just sitting over there with no. Of course, it is internalized inside the cytoplasm, but the cells are not phagocytosed at all. And so you never see, say, in Rosai-Dorfman disease, which is the exemplar of emperipoiesis, you do not see any destruction of the cells of the phagocytosed lymphocytes or anything else within the cytoplasm.
There is one more question from Mrinalini. It's regarding ABV positive inflammatory FT sarcoma. She asked why could this be occurring specifically in spleen?
Mrinalini, I wish I knew, but it occurs in the spleen and in the liver. And perhaps because, there is a concentration of EBV in these organs. I have no idea why this happens. And if anybody knows, I'd be very happy to know the answer to that. It is just a clinically well-established correlation between this inflammatory, what at one time was called inflammatory myofibroblastoma-like follicular dendritic cell tumor with associated EBV. I don't know the answer to that question.
Nidhi asked one specific question to Borges madam. Kindly tell me a good journal for histopathology.
Sorry, what? Somebody's asked a question saying what?
She wants a good journal for histopathology.
Good journal?
Yeah.
I'm not sure. Are you a postgraduate student? Nilalini, is she a postgraduate?
It's Nidhi.
Sorry?
It's Nidhi.
Nidhi.
Oh, Nidhi. Nidhi is asking.
Yeah.
Okay. Sorry. Nidhi, I don't know how to answer that question. I don't think that there is any one journal or even one textbook that can help you. You have to learn from your experience when you see a whole lot of cases. You are exposed to them in your postgraduate curriculum, and every time you see a case, whether you have seen it before or you have seen it 10 times before or just once before, you must correlate all of that with your textbook, as well as any kind of journal which will give you some information on this. And I think journals are useful when you don't have something that is very common. Then you can go and look up details which you may not find in textbooks. Otherwise, your textbooks are good. Sit with your textbook next to you and look at your cases. And I'm not saying that this is only for histopathology. It's true for anything else.
There are no more questions in the chat box now.
All right.
Thank you, ma'am.
Thank you, madam.
You're
Thank you,
welcome.
ma'am.
Thank you, both of you, very much. And I must thank Manju for waiting till the very end. It was my pleasure to to talk to all of you. And I just thought that I would present these cases because, youngsters are not going to see this. They're rare, as Manju said. And what did you say, Manju? You only see about 15 or 20 in a year?
Yes, ma'am. So that's
So
the
if the Tata hospital sees 15 or 20 in a year, this could be like a lifetime's collection, for some people who are not in a. So I hope that the students enjoyed it. And the first part was just to give them a flavor of what happens in with the same diseases, but being looked at by different authors and different societies. Thank you very much.
Thank you, everyone. We have an upcoming talk on flow cytometry in lymphomas by Gujral sir on October 7th. Thank you all for attending our webinar. We'll
Thank
end.
you. Thank you,
Okay.
Rita.
Thank you.
Thank you, sir.
Thank you.
Thank you. Bye.
Thank you. Bye.
Thank you all.
Bye.
Bye. Thank you, Nidhi. Thank you.
Bye.